The haircut,
Nobody
I
knew
like
what
it.
the-
I've never seen that before. I like it. Looks good. I'm Sue Latosha. I work with the Stockland region of Advocates, so that's Christ, Trinity, and South Suburban, in regards to bringing outreach to you on any type of help.
And she's the one who finds us, or she's the one who gets us here. She's the one who uses the topic based on what you want to hear. I don't
Exactly.
think I need a microphone,
So
right?
that's why
Everybody
these
can hear me now.
evaluations are very important, because you can let us know what you want to hear, what's important to you. So if you fill that out, we greatly appreciate that before you leave and hand it in to us. But anyway, Dr. Bhan is here. He is the director of the Heart Rhythm Lab at Advocate Christ Medical Center. He is also director of the electrophysiology, which is the same thing as heart rhythm, fellowship teaching director at the University of Illinois, Chicago. And he has been speaking for us and affiliated with Advocate for years. We're very happy to have him. He is clinical cardiac board certified in clinical cardiac
You make it
electrophysiology.
difficult so that people don't really understand. But I'm the electrician of the heart.
Yeah. So if you've got irregular rhythms, he knows what to do in many different ways. And his office is on 10837 South Cicero in Oak Lawn and 17850 on Kedzie in Hazel Crest.
Thank you for organizing all this. And like I said, I'm really happy to see some faces, because you never see an expression when you're doing these, remote talks, because, crack a joke and you don't know what to do. So it's smiling around. So anyhow, I'm going to start with, how do I forward?
Left one.
Oh, from here?
Yep.
All right. So these are the common questions that I'm often asked, whether it's my patient or somebody else, sometimes family members. It's like, and again, just for, raising hands so that I know how many do have family members or anybody with pacemakers, defibrillators. All right. So again, I'm sure you have some interest in that, and therefore we are here. Many a times these are also confusing in the sense that do I have a pacemaker, do I have a defibrillator, what does one do, is it the same? And those kind of questions are just the starting point. So, and then the questions, of course, these are some regular questions that are often asked to me, and we'll answer them at the end or in between, whichever way you think. What do I need? Do I need a pacer or defibrillator? Are they not the same? No, they are not. They're different, and we'll go over there. How's it done? Is it like an open heart? Do I have to stay in the hospital? No, it's not an open heart. Anything simpler, we call it procedure. Anything complex, we call it operations. We put it in the procedure category. So it's not in the operation category. Stay overnight, go home the next day. Do I have any restrictions? Well, with the newer pacemakers and defibrillators, there's really not too many restrictions out there. Even their MRI say microwave is for the 18th century. You could almost do everything. I have patients with pacers and defibrillators who go mountain climbing, scuba diving. There was one particular young adult patient of mine who actually went skydiving. And I'm like, all right, I'm glad you didn't tell me that before. But what I meant is that there's basically leading everything they want to do and the quality of life they want to maintain. What if it stopped working? No, I mean, it's just like, it's more reliable than the car. Your car can stop working at any time. Humans are not perfect, so no machines are perfect. So but it's 99.9%, which is as good as it gets. How long that lasts, and we'll go over that later as we start. Let's start with the basics first. So before I go into these, I like to start with cases, but before I talk about a case, when people think about the heart, they typically say heart attack, blockages, stents. That's what typical heart disease is. But there's an active electrical system in the heart that regulates your heartbeat, that keeps your heartbeat going 60 to 100 beats a minute. I mean, it's an amazing creation, and I'm philosophical, I say amazing creation of God. It's like how, no matter how much science gets advanced, it's like how this is programmed. The child gets born and you have a heartbeat going at 60 to 100 beats a minute, and does it for the rest of the life. But then there are times when everything's great, just like your own electrical system in the house. I need a change of wiring, things are needed. And that's how pacemakers come along. So we're going to start with the case and see if it kind of fits anybody's story. There was an 8-year-old female who had been feeling more tired with worsening shortness of breath for about a month. So it was coming on gradually. Then she fainted at the grocery store, and the common things are, oh, she didn't eat, she didn't drink, that's why she fainted. Well, ambulance was called, patient was brought to the hospital. She became a little dizzy, but overall was feeling okay. Now, the proof usually is in finding what happened at that very second when somebody faints. And sometimes we get clues later, but sometimes we don't, because by the time they recover, everything is good. So this patient, this is just the electrical system background I was trying to, I think I misplaced this slide. This was supposed to be the first one, but I don't want to get into the complexities, but I was just mentioning there's a complex electrical system in your heart. So we call it the main powerhouse. So you have the top chamber and bottom chamber. People familiar with the heart, like 4 chambers, 2 on the top, 2 on the bottom, something like that. So on the top right, there's the main switch. This is where all the signals arise from. And then this is a fine electrical system that spreads throughout the heart. And I call it between the top and the bottom, there's a bridge. So the signals then come down the bridge into the bottom chamber of the heart. And when the electrical system gets to the bottom chamber, that's when your heart beats. So no matter how strong your heart is, no matter how clean your arteries are, no blockages, until you have this electrical signals come to your heart and give you a heartbeat over here by pumping your heart, you won't get a pulse. So this is the electrical system. And the problems where people have, where you need pacemakers or the electrical system is wearing out, if I put it in 2 big areas, it's either the main switch goes bad, so the heartbeat is not being generated, or the bridge gets bad, where the signals are not being converted or transmitted from the top to the bottom. So those are the 2 main areas where the electrical system wears out. When the electrical system wears out, that's when people start getting tired, short of breath, fainting. So if you look at this thing, and again, I'm not here to make you all experts in EKG, but this is quite obvious to the naked eye. Your heartbeat is going, and then guess what? It's a big pause, right? So this is how heartbeats first regenerate. They get pauses, they stop working intermittently, and you may catch it or you don't. If you're wearing a monitor, you may see it or you may not. And then eventually, if this gets longer and longer, you start fainting. And sometimes, if it's in the bridge area, this is the starting point, this way it looks narrower. If it's in the bridge area, there's connection lost between the top and bottom. This can be fatal. So the main situations when they are heartbeat slows down, you could either faint. If you're catching it early, that's great. Fatigue, shortness of breath, new onset, you could walk up a flight of stairs, now you can't do 2 steps, something is wrong. We blame it on aging and everything like that, but now we could do it yesterday. Why can't we do it today? That's an abrupt change. So an abrupt change in symptoms, that's the classical description is. Now you can't do it. Maybe your heartbeat is slowing down. Because what happens is you can do with a heartbeat of 40 or 50 when you're sleeping. And most of us will have a heartbeat of 50 when we're sleeping. We don't need it. But when we're laying down, that's enough to keep our blood supply going to the whole body. But when you sit up, then it should be 60. When you walk, it should be 70. When you run, it should be 120. When it cannot keep up with the demand, that's when you start getting fatigue and shortness of breath as the earliest symptoms. As it progresses, you start fainting, and sometimes it could be lethal. So this is what it is. We replace the electrical system in the house. You have a 75-year-old house, it has an electrical wiring that needs to be replaced. We call the electrician to replace it. This is your artificial electrical system that needs to be replaced. You have 2 wires that go to the inside of the, there's no cutting open in the wall. There are veins under which, just big IV lines. You go through the veins under your collarbone, and we basically thread these wires into the heart. And the end of it is connected to this little can that sits under the skin. So there's really no cutting open involved. The incision you see is only under the skin to accommodate this. It's not going in the heart. It's the wires that go into the heart. And the electrical stimulus is provided from this pacemaker that goes and stimulates your heart. And there's one wire on the top, one on the bottom to mimic your natural heartbeat, where you know the heart beats on the top of the heart. That's what a pacemaker does. Give this. So this is just another view from the inside of the heart. You can see it goes through a vein under the collarbone. And then these wire, one on the top chamber, one on the bottom chamber. They have active screws on it. So, you know, we can basically screw from the outside and they get attached to the heart muscle, both on the inside and on the heart. That's how a pacemaker looks like. So like I was mentioning to you, and you know, we try to mimic the pacemakers to what a normal heartbeat would do. So when you're resting, your heartbeat could be 50 or 60. Sleeping, you sit up, it goes up a little bit. When you walk, it can go 70, 80. When you're running, you can even go 140, 150. Somebody's own heartbeat, which is 20 or 30, can reach 150 when you're running. So that's why people get the same quality of life back once they get a pacemaker. So before we go on to the next case, any questions? I know it may sound confusing. We'll come back to more questions, but just don't want to leave the pacemaker part here without getting some understanding about it.
Is that a pacemaker constant or is
Yeah.
it adjustable or something's going on?
Yeah, so the way it works is it's supposed to mimic, so it's automatically working. And so there are two ways of it. If you're totally dependent on the pacemaker, meaning you have no heartbeat of your own, and that happens often, then it mimics like I showed you on the other slide. Yeah, automatically 60, you walk, it becomes 70, it becomes 80, you're running, it becomes 150. On the other hand, there are people who use pacemakers only sometimes, not all the time. So the way the pacemakers behave is again automatically. If it sees your own heartbeat come through, don't shut up. Because it prefers your own electrical system, because the own electrical system is better. So it prefers its own electrical system comes through, or own heartbeat comes through. But when it sees that it's taking a pause, like we saw that other EKG, and you're going to get dizzy and you're going to pass out, in a microsecond, it kicks in. And you do not know about it. To you, your heartbeat is always 60 or higher. You will not know that your heartbeat is dipping to 40 or 30. Yes, this is totally all right. Yeah. How long it lasts? So these batteries, you know, it's always the question that people ask is, well, why doesn't it last forever? You know, why can't we recharge it? Well, then the people who are making it, you know, they'll be out of business. So I guess they don't make it that easy for us. But they're being pressurized by us many times, or many years ago, these used to be so much larger with lesser functions, and it was uncomfortable. They used to put it in the stomach. Now they become smaller and they can just be put up here. It's about this size. But now they're lasting longer. So I would say these on an average would last anything between 10 to 12 years.
So then you take it out.
So most of the time the wires are doing fine. So what we got to do is we just disconnect the battery. The whole unit is called a battery because it's a misnomer also. It's the whole unit. We take the whole unit out, connect it. Takes about 20 minutes to do. We keep you another hour or two. Now when you do a fresh pacemaker, we keep you overnight. But when we're doing this as a change out, we send you home in 2 hours. It's not right through yet. Maybe it'll be right through soon. Sorry, I had some questions.
Already answered the question about the battery.
Okay. Yeah, it's like, did you have a question?
It was related, but I wasn't clear on the difference between just a change out 2 hours and overnight.
Yeah, so when you put a new one in, we keep you overnight. And the reason for that,
But you need a new one, why would you need a new one?
Right.
After the battery.
so yeah, it's because of the unit that the battery has run out. So you need a new battery. But what happens is there are two components to it. There's the wire and then there's the can or the pacemaker battery, right? So what happens is when we're doing a new pacemaker, you have to go to the vein and put all the wires in your heart. That's the more tricky part. That's the little bit more riskier part. That's why we keep you overnight to make sure everything is well settled before we let you go home.
You just mean the first time.
The first time.
Oh.
But the next
I
time,
mean, the back.
right, the next time, if the wires have to be changed, it goes through the same process. But if the wires are working fine, which it does in majority of the time, then all you do is you change the unit out, connect it, and send it home.
How do you know when the battery runs out?
Right.
Yeah,
So,
how do you know when you?
and we'll discuss that again a little later, but what happens is we monitor you. Technology has changed that we give you equipments that we monitor you wirelessly to your home. So we give you an equipment that you basically plug into your room, and every time you come into your bedroom, it picks up the signal and transmits it to us. So if everything is fine, you don't hear from us. If something is not good, you will hear from us.
That's perfect.
Yeah. And the way it goes is, it's not like, oh, your battery is going to run out. It's 11 years now, you're done. Your battery is going to run out. Some people run out in 8 years, some in 12 years, 14 years. So you know how you're driving a car, you see it comes to the empty or the yellow light, and you still have 30 miles to go. So it's not like the day it goes down, you have to have it changed. You still have 30 miles to go on translating into about 3-4 months before you change. And there are certain alarms that come up that you see or hear some buzzing here that gets your attention. But even before that, we can see that and we call you and tell you, hey, your pacemaker needs to be changed. In fact, you see the trend, like when you're driving, you see your gas is coming down and down. When you come for office visits, we tell you, another 6 months left, another 3 months left. And then when it comes to that point, then
When that buzzer goes off, on what time frame do you have to?
at least 3 months.
But the buzzer goes every day at the same time.
So what happens is, once it goes off, because it's a little nuisance, and this buzzer was more important in an era where we didn't have this wireless connection information, because we didn't know what was that. So if you see me today, I may not know what's happening in the next 365 days if I see you once a year. But if the buzzer goes off, it catches your attention and tells us that his pacemaker needs to be changed, or there's some other malfunction, or we need to get attention. But now, because we can see it, we know it too. And the whole idea is you don't sit on it for 3 months and get buzzed every day and hear the nuisance. You come to our office or we call you and we just turn the alarm off. And at that time, we plan with the doctors and get you set up for the next date when you can get it.
I went into a panic, they were told me at 24 hours. I was in Denver. And it went off.
Next time it happens, tell them, I know. I'll tell you later. I got 3 months. All right.
Who determines whether it needs a pacemaker or a procedure or something?
No, so the pacemaker is what you mean, who determines this?
Yeah.
So the starting point is symptoms, right?
Okay.
You go to a doctor, because this fatigue and shortness of breath can be caused by a whole variety of problems. It's when the doctor evaluates you or does an EKG or checks your heartbeat and finds it to be slow. That's when you get to the path. Yeah.
Okay.
That's when you get to the path of, oh, you need to see a heart doctor, or the heart doctor will say you need to see a heart rhythm doctor. That's when you come to me. On the other hand, if one goes to the extreme phase right away, which is not gradual fatigue, not gradual shortness of breath or gradual dizziness, just faint, then you're in the ER, you're in the hospital. And then we see it right away, what's happening, because then it's very obvious, because fainting is a more advanced form of when you need a pacer. So when you need it urgently, when you're in the hospital, or when you start fainting, then you need it more urgent. When it's something with fatigue and shortness of breath, you can probably do it in a week, 2 weeks, something like that. Okay. So this is a different story. Now we're changing gears here a little bit, because we talked about pacemakers and defibrillators, and I want you to understand they're not the same. They appear to be same, but they're not the same. So here's a different story. There's a 70-year-old male who's had a history of heart attack previously and has had open heart surgery. He's walking in the park and suddenly collapses. Now, there's a difference between fainting and prolonged fainting. So fainting is something that somebody would just pass out. And by the time somebody says, hey, what's going on? Or put some water or, kick you around, you're up. And you're like, I feel fine. But when you have a cardiac arrest or prolonged fainting and you need CPR, that's cardiac arrest. Now that's also a misnomer when people call, oh, he had a heart attack. No, heart attack is when you're having chest pain. Heart attack is when you're having, you're going to the hospital and getting stents and getting angioplasty. Sudden death means you just died. And then if you were lucky enough and somebody was around you or the paramedics called you in a timely fashion, you make it alive. That's what sudden death is when you start CPR. In the state of Illinois, do you know how many people make it from sudden death?
3%.
Close enough, one. Wow. So 99% don't. So that's why there's so much of importance in CPR. And we try to teach kids who is working on some schools to help us because that's where they need to learn this. I saw a very interesting thing. I don't go on Twitter and all much, but I saw an interesting post from Africa where a pet monkey had a sudden death and the guy, he resuscitated it mouth to mouth and got that monkey back. And that was like, it's not a made up, it's real. You can see it, how happy he was. But coming to that is like, of course, we got to say humans too. So this is how the heart behaves. So this is, again, not trying to teach you EKG, but when you saw when somebody needed a pacemaker, the heartbeat was stopping, there was a flat line, right? Now, when you're in cardiac arrest, we say arrest meaning heart not beating, right? That's what we would normally think. But it's the other way around. It's going so fast. You see how many Wiggly lines here there? It's going so fast, we call it ventricular fibrillation in technical terms. It's going so fast that it's incompatible with life. It's like you can't have a heart go 400 times a minute like that and have enough blood in it because you need to fill blood, then you need to pump blood. Fill blood, pump blood. If you're doing this, there's no blood. So no blood in the heart, so nothing is coming out. So we call it standstill of cardiac arrest. This is what that patient had who just fell down and had to be resuscitated. So this is where you see you have AEDs around, you do the resuscitation and call paramedics, AEDs around, give them a shock, you save the life. Now, this is just another slide on this, which we already talked about. This is old data, but there are about 450,000 sudden deaths in US each year. And I said 5% because I took the Seattle criteria. Seattle people are the best in CPR, so they can resuscitate more people than Illinois people can do. But we're going to get there. So who are these patients who are at a high risk for cardiac arrest? So we talked about pacemakers. Who are risk for pacemakers? It's just getting old, electrical system wearing out. There are other reasons for it also. Sometimes there's infection, there's genetic problems, there are certain medicines, but it's just wear and tear that makes your heartbeat slow down and you get a pacemaker. But cardiac arrest can happen at any age. There's some genetic syndromes that can happen. There are people who've had heart attacks at young age. They've had what we call cardiomyopathy or weak hearts at any age. So we see this in any patient. You have basketball players who you suddenly see drop dead. They have got some genetic syndromes. They have to be resuscitated. There was a player in Europe who just had a cardiac arrest. Fortunately, he made it alive, wanted to come back from the game, but of course you can't. So the people who are at a risk for those are those who've had heart attacks in any form, bypass, heart attack, and who have a weak heart. Are you guys familiar with the term heart failure or weak heart? So there's a term we call ejection fraction. Anybody heard that term before? Okay, I'll tell you about this. So ejection fraction, or we also call it EF. So when the heart pumps the blood, it's supposed to evacuate at least 50% of the capacity. So what that means in simple words is a normal heart muscle function is 50% or more. It doesn't mean it's working at 50%. it's 50% or more, is normal. Anytime you have a heart attack or you have what we call cardiomyopathy, where the muscle is replaced by scar tissue from an infection, even COVID did it. You know, when you talk about myocarditis, I don't know that term with COVID, when you hear that. So anytime the muscle is involved in any form, directly by infection, high blood pressure, alcohol, cocaine, they directly infect the heart muscle, or indirectly through blockages, heart attack, that causes the heart muscle to get weak. Now, why is that? Because the muscle squeezes, scar doesn't. So more scar you have in your heart, if you've had a big heart attack and it's been dead because of the blockages, then the muscle becomes less. And then this pumping function that is supposed to be nice and strong is now pumping weaker. And the scar tissue, which becomes sites of what I call electrical storm, and they can cause you to go into a cardiac arrest with them anytime. And just when we look at these numbers, if you've had an echo, and just go and see what your EF is. Above 50 is normal. If it's below 35, you need some attention. And the reason for that is because most of these defibrillators we give is for prevention. Now, pacemakers we don't give for prevention. We give it when there is a problem. But defibrillators, most of them we give for prevention. And why is that? We just talked about it. Because 95% don't make it. So we are on the lookout for seeing who are the people out there who are at high risk, so that if we can protect them in a timely fashion, then we can prevent them from having a cardiac arrest. Because otherwise, if we just wait for a cardiac arrest to happen, we're only going to save 5%, not the other 95%. And the starting point of how we screen for these people who need a defibrillator, we have to look at one single number. This is the starting point. Yeah.
When I was going through the cancer treatments, they used to always have me do the ejection fraction. And then once that ended, are they just looking for something during that time and then it's okay after that?
So very good question, and I didn't go into the details of it, but it's a great question because the two major categories that cause the heart to get weak, one we talked about blockages, and the other is where it affects the muscle directly. So I talked about a few things: alcohol, cocaine, uncontrolled high blood pressure, viral infections. But chemotherapy drugs is another thing. So when you're going through, especially the breast chemotherapy drugs, you go through those. There are some drugs which are very effective, but they can be toxic to the heart muscle. So when they are giving it to you, they have to periodically check to make sure that it has not affected the heart muscle. And going forward, if they see that it's affecting the heart muscle, they may want to back off from those medications.
Okay, so would that be fast so that nothing checking?
No.
Whatever.
There is a time for a few years after that where you might check it once or twice a year. I would say once a year for a couple of years. But beyond that, no. Yeah, I mean they can, but they check it as a general rule for every chemotherapy because some may have it more and some may have it less. One other situation in young people is post-pregnancy. We have people who go through pregnancy and they develop cardiomyopathy after pregnancy. And that's another big one for heart muscle failure. So, like we talked about, it's the same thing. If you remember the last X-ray picture I showed you, is the pacemaker stays here, wires go in into your heart on the right side, one on the top, one on the bottom. Now the difference is, many years ago when these defibrillators first came out, they used to be pure shock devices, meaning you're going into cardiac arrest, it's just going to shock you and save your life. These work automatically too. It sends the signals all the time. And then there were people who were needing pacemakers. So what happened is they had to put a pacemaker on one side and a defibrillator on one side. So now what we do is that we incorporated the pacemaker and the defibrillator. So every defibrillator has a pacer capability. It doesn't mean it's going to be working as a pacemaker, but if it is needed, it can work as a pacemaker also. Having said that, pacemakers don't work as defibrillator. Pacemaker is pure pacemaker. But if you have a defibrillator, when somebody says I have a pacer defibrillator, that means it's a self-understood thing that you have a defibrillator, and every defibrillator has the capability of being used as a pacemaker. Now, when you see those, shocks that the energies that they are delivering, paramedics, like two paddles. So these are your two paddles. There's this can and there's this wire. They are the ones that charge and shock. And they do it in a matter of less than 10 seconds time. I call it your personal paramedic. Regard the name, whichever you want. You don't even have to wait for paramedics. Nobody's going to arrive in 10 seconds. This takes care of you in 10 seconds or less. So these are the people we identify, high risk for cardiac arrest, have to get them protected. They've not had anything bad to happen to them. And this is the question I sometimes am very challenged, especially my biggest problems are with the younger people. They're like, oh, I'm fine, I don't need anything, I'm good, I'm feeling good. You're feeling good, but I see something there that I'm worried about. And not that I'm biased against age, I want everybody to live 120 years. I was just going for my life insurance and they said it's for 120. I'm like, really? Do I need life insurance for 120? But that's what they were trying to sell. I'm like, what if I just stay for 75? Like, oh, it doesn't change. Fine. Anyhow, but I want everybody to live to 120. But the thing is, I'm more worried about people who are 40, 30 years of age because they have a whole life in front of them that can be protected as opposed to 80, 90-year-old. In fact, many of my 80, 90-year-old patients, they don't even want it. And I probably am with them, If by God's grace I reach 75, 80 and my time comes, this is the best way to go, painless departure. But when you're 40 and you're 50 and your parents are around and everybody is around, your kids are young, you want to be protected. And that's my hardest step in trying to get them convinced because this is a prevention thing. It's not like a pacemaker that I've had problems and I need. But it's very important. And that's why, when we sit down during the first visit, I have to spend a lot of time in convincing them why they need it. But it is very important and it works 99.9% of the time. It's a little bigger than, I would say, 2.5 times bigger than a pacemaker because it has more functions. It's, if you look at the paddles, how big that is, it has to, it has been, shrunken and made that happen. This is again just telling you that if you go into a cardiac arrest, it's going to shock you. See how your heart starts going fast. Then within a matter of seconds, it just gives you a shock. Back slow. So many times the question being asked is, can I feel the shock? The answer is yes and no. Majority of the time people do feel the shock. And they feel the shock if they've not passed out. If it is so fast and furious that people pass out, then they may not know that they got shocked because they had already been passed out. Otherwise, you would feel it. And there's no guessing in whether you feel it or not. I mean, the most extreme form somebody has said is, like a horse kicking your chest. But the good thing is it's short lasting. It's not like a lingering pain. It's like came and gone. So it's not like I had the shock, now it's hurting. It's not. It just came there and comes with no warning. Because you could have cardiac arrest anytime. You could be playing, you could be sleeping. Sometimes spouses discover that they had a shock. They don't know because they were asleep. It happened in the sleep and she just saw him jump at night. I'm like, what was that? But we know about it when we come in the morning. Those tracings from his remote monitoring have been sent to us and we call them. Something happened last night. Yes, he was jumping in bed. Like, yeah, he's alive because of that. Yeah.
People that have gotten a pacemaker, would they eventually have to get a defibrillator?
No, total different problems. Like I said, the pacemaker is the heartbeat electrical wires going down. Defibrillator is muscle damage. It's muscle damage. Now, I don't want to get into too complexities, but there is a small set of patients who have pacemaker need and they are always using the pacemaker. Always using the pacemaker can sometimes, not all the time, sometimes weaken the heart muscle. So sometimes we can overcome it by putting 2 wire, 3 wires, and rarely we have to put in a defibrillator. But as a general rule, I won't think I'll keep them separate. These are these details. So there are some, so defibrillators come in different wires, and it becomes important to say, do I have one wire, two wire, or three wire defibrillators? So the one wire that goes on the top is basically the pacemaker wire support. The bottom one is the shocking wire that helps. Now, it's great to live long, but it's better if you feel good and live long. So there are some heart failure patients where the heart muscle is not only weak, but it is out of sync. What that means is that the right and the left are not squeezing together. So when the heart is not working together, the heart beats the right side, left side, it makes the pumping function worse. In such scenarios, we put a third wire on the left side of the heart. And this actually goes in a vein and sits on the outside of the heart. These two are inside the heart. This goes on the outside in a vein. And what it does is it takes the heart muscle, something we call that wonder branch block, but you don't have to remember it. But it's just the heart muscle that is going out of sync, it makes it work in sync. And that improves how you feel. Actually, I feel so good when I see patients who are eligible for this as opposed to only a two-wire. Because only when I get a two-wire patient, it's like, yeah, I'm going to save your life, but you have to be dependent only on the medicines to make you feel better. But when I see somebody who needs a three-wire, I feel good that, oh, he's going to feel better with this also, not just save his life. But there are concerns too. Nothing is foolproof, you know. The risk of these, devices is low, but nothing is zero. The thing that I am most paranoid about is infection. Because as ugly as it looks here, if it gets infected, we have to take everything out. Because the wires in your bloodstream, they go into your heart, can infect your heart, and it's a nightmare. So every time I do a pacemaker or defibrillator, I pray that it doesn't get infected. And it's not a high incidence, it's like 1% or so. But for a given individual, it's 0 or 100. You're the 1% that, that's it for you. But that's the thing I worry about the most. Therefore, a lot of precautions we tell our patients after we do it is that, follow the instructions, don't do heavy lifting, don't do driving. We have a period of about 2 weeks when we ask people to take it easy. Beyond 2 weeks, it's all good.
Is it infection due to the wire or?
It's a local incision site. Now, there are times when the defibrillators can be affected secondarily. That is, many years later, they can get infected. If there's infection anywhere in the body, the hardware can be secondarily infected. And if it gets secondarily infected, then you have to take that one. But this is more like at the incision site, which is something you would see in the first 2 weeks' time. And then sometimes if you're not, compliant and you start driving with heavy lifting because you think you're macho and you're like the strongest man on the road, then the wires can sometimes move. This is a wire that moves, but I don't want it. It's important to show it to you, but I don't know if you can appreciate this wire here. So it just fell and it's like straight now rather than a curve here. But then you have to go back and do it again. So those are the two things we worry about. Therefore, the restrictions of, how do I go back? Right?
Yes, if you right click and then previous.
My hands are not shaking.
There you go.
No.
Yep.
Correct. So there are situations when we can't give conventional pacemakers and defibrillators. One, when there's a risk of infection, because you don't want to go and give somebody who's already infected with it or has active infection going anywhere else. So, or there are some patients who are very high risk for infection, like dialysis patients, because they already have catheters, they always have course of infection going on, they were infected. So in those situations, we sometimes put another defibrillator, which is called subcutaneous, which is We put it on the outside of the chest, just over the chest wall. Nothing is in the heart. It's all outside the chest wall. They're good, but they're second best because they don't have good pacing capabilities as opposed to a defibrillator, which if needed can work as a pacemaker. These are only pure shock bombs. But it's good enough for people who are at a high risk and can't get any other things. So, or if somebody gets infected, what do? Then this is another option for them. If people have pacemakers and get infected, we sometimes put wireless pacemakers. We call it leadless pacemakers. These are these small. Actually, this is almost correctly. This hand is big, so, but it's not that big. It's about the size. And we go and deliver it directly in the muscle. So there are no wires or any leads or no can or no generator. Nothing is there. Just go to the groin and do it. So these stand there, and they're also more in evolution, and they're getting better as things stand. They're not as good as the regular pacers, but it does the job majority of the time. And this is something we might be heading for in the future, because the two commonest problems like I showed you is infection and the wires going bad or the wires getting dislodged. And when you have no wires, and you have no can or no incision, you don't have to worry about infection or the wires. So this may be thinking more of the future. We've had this for many years now. There's a subgroup of patients we utilize in mostly, like we talked about, same group of high-risk infection, dialysis patients, or patients who've had infection. Sometimes veins are closed. There's no access because in order to get into the veins, we have to go to the left or the right under the collarbone, we call it the subclavian. If they're closed, you can't get into it and just under the dog. Sometimes the person is very sick, cancer patients and all, just try to keep it simple because you start chemotherapy and then you increase the risk of infection and so forth. So this is another second best option for that. So this is what we already started talking about, but we'll go in it again. It's like, how do we check on you? How do we keep an eye on it? Of course, when you come to the office, you can put a little wand on top of your pacemaker. It spits all the information out on the computer screen. We can reprogram, we can check it. For example, you're very athletic, okay? You're walking and you can get your heart rate 120, but you know what? You get tired at 120. I want my heart rate to go 150 because I can run, So we'll reprogram it. Nothing to be done, all electronically. Next time you're running on a treadmill, you get 150. There's another gentleman there who goes to 120 and starts having chest pain because he can't tolerate such heart rate because he's got blockage issue. I'll program his rate to make it 100, so he doesn't go above 100. So those are the kind of changes we can make to fine tune according to the needs of the patients. So that's one part. But the second part is we monitor you from home. Now we can't make the changes when you're at home, but if we see something that is out of the ordinary, we call you to the office and then we'll make those changes accordingly. But we are monitoring you. So like I said, you have a device that goes to your home with you. Whichever brand company you have, you're basically plugging it into the wall. Nowadays, for those who are smarter, they have the smartphone. I don't know why they call it smartphone, but everybody's smart. I mean, so what? It should be advanced phone. I don't think it's smart, but I can't operate. But it's just a generation thing. But yeah, I mean, the younger ones, they work good on their phone. So they download and they can work everything with their phone. For others, they just use the equipment. Okay, plug it. When you're in that room, it's there with you. You go, if you're going for a vacation, they ask me, should I carry it with you? I said, nah, don't worry. Come back in 4 or 5 days, pick up everything that happened over the last 4 or 5 days. Going for months, then sure, take it with you. If you're using it on your phone, then it's much easier. You don't have to carry anything. But we get all the signals from the home monitoring device. These are all on the cloud. And then they come and we can download on our computer. Unfortunately, we don't work 24/7. But these things, the first thing we open in our office, we get all the alerts at 8 o'clock. So I would say a reasonable time approach is within 12 hours. People know all the alerts that come through. And then we reach out to you and tell you what to do or not to do. If everything's staying good, you don't hear from us. These forms come, I sign off on them. The Medicare bills for them. That's it. But that way, we know what happens in between. So this is what we call remote monitoring. That's why that through this we can do periodic check on how device is functioning, make sure everything is good. If you're feeling odd or something bad that day, I don't know, I felt my heart race, I felt a little dizzy. You can send an extra transmission directly from your home. You don't have to come to the doctor's office and say, I need an appointment. I'm not feeling good. Can I just send a tracing? You can send a transmission and we can see what's happening. You can say, don't worry, it's not the pacemaker. Don't worry, it's not the defibrillator. Or there is coming. But that way we can avoid unnecessary office visit or unnecessary ER visits and so forth. It also monitors for various heart rhythm disorders. Anybody heard about atrial fibrillation or other things like that? Okay. So what happens is these record a lot of other heart rhythm. This is the best monitor system. If you've been in the hospital for anything, they'll put you on a monitor and they're checking your EKG, your rhythms 24/7, or sometimes you'll be sent home on monitors to wear for 24 hours, sometimes even for a month. So this is 24/7 recording, like continuous monitor. And we pick up things. The biggest thing that I always like to say is the atrial fibrillation is another rhythm. We talk about atrial fibrillation as a separate talk sometimes, is it has a risk of stroke. And what happens is many times people end up with stroke and then we discover they have abnormal heart rhythm problem. What we've seen in patients who had pacemakers and defibrillators is we pick it up before something bad happens. So we can protect them with a blood thinner or other needs that they need so that we can prevent stroke. So these are useful beyond working as a pacemaker, beyond saving lives. They're also useful in looking at other heart rhythm problems that could come along. If you get a shock, we talked about it, we will know even if you didn't. So, even if you were sleeping or you had it and you passed out. Certain devices will also know if you're having fluid buildup. So, if you heard about heart failure, they say, oh, he's swelling up, he's got more fluid in his body and he needs some water pills or he needs to go to the ER. We can see that too. It also tells us how much daily activities are doing. Oh, he's not walking more than 2 hours, or he's being in bed all the time. We can see all that. Those are algorithms and we can guide treatment not just focused on the pacemaker defibrillator, but you as a whole. You need to walk more, you're not walking. Your sleeping hours, your heart rates are going fast. You need to change your pacemaker. Your fluid is building up, you may be getting more water filled. So it works beyond just the regular pacemaker and defibrillator.
So who do you share all that information?
So it comes to us, and then we share it with the patients. So precautions, often questions asked, what about airport? Is it generally safe to go to airport or other security detectors? Yes, it is. And if anything, it's better, if you go, at least so nowhere, I know there are big signs everywhere. If you have a pacemaker or defibrillator, let us know. And they screen you different. Even if you don't have a ESA pre-check or fast check, that is a faster route. You can go that route and they'll check you and get you through. Now, the only thing with the modern devices is it will beep. It really doesn't do anything. But if you go through it, it will beep. So you'll be, because it's a metal, so they will get you out of the line because it detected something. But if you tell them ahead of time you have it, then there's no issue. They give you a card, it's like an identity card that you carry with you in your wallet, a small card that works also. I have had one scenario where the defibrillator has shocked some person inappropriately, and don't ask me why he did it. He was at the old Carson's, okay? He was in that store and he was hugging onto that sensor when you walk in, God knows why he was doing it. And he was hugging onto it for a good 30 seconds and it sent some signals and it shocked him for a wrong reason. But I don't think anybody in this room has gone into that, so I don't know. But that's the only situation. But otherwise, even the new devices are MRI safe. If you have at least the newer generation pacemakers, defibrillators, and when I say newer generation, meaning anything after maybe in the last 10 years or so, they're all, majority of them are safe. If you can get an MRI needed, because conventionally it's been said, oh, you can't get an MRI, but you can. There's certain things which, again, you can read through this, but if you're working with large motors, cars, or boats, especially working on a car, the engine running and the hood open, you can sometimes get wrongly shocked. And the reason is the defibrillator picks up signals from that machine and thinks it's a cardiac arrest rhythm and gives you a shock inappropriately. Same with high voltage machines or power filters. For cell phones, this is the question often asked, especially it has been seen with the newer iPhone 13, and I don't know anybody is being aware of it. It's like if you put it in your pocket, more for men than for ladies, then it can turn your defibrillator therapy off. How often does it happen? It's not very often, but it's been seen with those smartphones. So we normally tell people keep it 6 inches away. So normally put it in your pocket is the best or your purse. That's the best place to put your phones. If you're having a surgical procedure, or let them know you have a pacemaker or ICD, because when they use cautery, that sometimes interferes with it. Most of the times when you're getting a surgery, they'll be sending us, clearance, so we will let them know anyhow. Sometimes radiation used for cancer can damage it, but the risk of that is extremely low. So I don't worry about it. It was more when in the older era.
You mentioned the phones, is that, are you referring to like the 5G or is that?
Yeah, the newer generation, anything with the 5G, and it came out more with the iPhone 13. That's how I know. That's what's the one that is getting most faster.
But is the issue something with the device or is it have to do with 5G?
I'm not sure about it. But again, that risk is extremely low itself. But what we normally tell people is don't put it in this pocket. As long as it's 6 inches away, it's fine. Can I participate in regular daily activities with Pacer or ICD? Absolutely. There's only a restriction period of 4 weeks. After that, I said, I've had people go skydiving. You can drive your car or travel once a year by a doctor again, 4 weeks period. If you get a shock, you normally restrict your driving for 6 months. And the reason for that, that's the hardest thing for me to do if somebody has a shock. But hey, good news, it saved your life. But hey, bad news, you can't drive for 6 months. And the reason is because we feel that in the first, not we feel, the science prove that in the first 6 months, you're more likely to have a second shock or a second cardiac event. And therefore, we restrict the driving, because if you're on the road, it could be at risk, not only to yourself, but somebody else. And it's not only a recommendation that comes from our society, but it also comes from the state. So in other words, we usually never report these out. I mean, we don't. But if they find out that you had a shock for whatever reason and you're still driving and something goes wrong, the license is suspended forever. So, but that's the hardest part I have. If you have a commercial driver, again, that's the hard one. School bus drivers, train drivers, pilots, they can't do their job again.
They have their license.
No, we recommend not to do because they have so many other people's life at stake. So that it will save your life if you're flying a plane or a truck. But if you pass out for that 5 seconds enough, it could be dangerous for so many other people. So those are kind of general recommendations. Everything else is okay. There's another good story. Been involved in the physical recreation sporting type, not to get involved in this or hit in this area. Sometimes people go and they come and check it out. Most of the time it's fine. But I can't tell you, I've been doing this for a long, at least 20 years. I've had at least 4 patients' lives saved because of pacemakers or defibrillators, because they got shot and it came right on the baser of the defibrillator. And it didn't get through it and save their lives. At least 4 I have. And it's like, oh, doc, do I need a new defibrillator? Like, sure, but you're alive. I mean, it's so strong, it won't penetrate through that. It's made of titanium. So metals and these are another use of, not that I encourage people to go in areas to get shot, but another advantage. We talked about replacement already. I think routine monitoring allows when this is planned. They last for about 10 years, I can say even 12 years. Defibrillators used to last 5 to 11 years, but now most of the defibrillators last 8 to 12 years. In summary, pacemakers are for slow heartbeats when your electrical system wears out, can make you faint. Once you get your pacemaker, you're back doing everything and more. Defibrillators are those for risk of sudden death. Most of the time, we give it as a preventive device in patients with heart attacks, heart failure, with weak hearts. Beyond the 2 to 4 weeks, we don't have any major restrictions except for younger individuals with competitive sports. There's still some sports that play, golf, swimming, competitive don't. And continue to monitor in the office and during regular visits. Right, time for another round of questions. We are on hybrid also, right? How do we, I don't know if I was able to communicate to anybody.
Yes, there's no questions in the chat for now.
Okay,
Yep.
but we'll open it if they have any questions, I'll be happy to answer with them also.
Perfect.
Yes.
You mentioned that if your heart is dependent on the pacer, it could wear out heart muscle. What can you talk about?
So what happens is, that happens in about 20% or 15% of the time. And the normal electrical system of the heart is such that when the signals come from the top, they go to both the right and the left. And the heart is supposed to be beating in sync, right and left together. But we put a pacemaker, we put it on the right side of the heart because the left side is such that any foreign substance you put in there, it forms clots. And clots leads to stroke and heart attack. So we don't put anything inside the heart on the left side. We only put it on the right side. And right side is fine. So when the pacemaker is working in somebody who's what we call dependent, meaning have no heartbeat of their own, their heartbeat is not working naturally. It's not synced. So this dysfunctional can make the heart weak in 20%. If we catch it in a timely fashion, we still are not weak enough to need a defibrillator. We can give a third wire, which I talked about. Now, when we put a third wire on the left side, we're not putting it inside. We go in one of the veins on the outside of the heart. And we go in a reverse direction and go up and put it on the outside. And then we can have them both work together. And the heart muscle that has been getting weak gets strong. Now, the question is, right. So the question is, why don't we put it in all? Because it's not needed. And this is additional wire. More the wires, more the complexity, more the risk. When it's needed, we do it in those situations. Yes, ma'am.
If the person is having heart issues, will it cause dementia and or dropping?
Well, heart issues is so fast, and I'm just because I'm more of a heart rhythm guy. So the one issue where I would say it does cause, change in the behavior pattern is when people have atrial fibrillation. Because when you have a slow heartbeat and you're passing out and you need a pacemaker, once it's there, back to normal, nothing changes. Now, when you're having that symptom before it starts, you may be tired and worn out before you get it. But it's not like it's going to affect your dementia or other things like that. No. Now, the defibrillator part, if somebody has had a cardiac arrest and it's taken a little longer for the paramedics to get there and shock you out of it, and your heart has been standstill for a long time, the brain is a very sensitive organ. So it gets affected. So you may lose memory for those people. Even though you're back alive, you've got some neurological issues or brain issues if there was a delay in getting you back into rhythm. That's why, again, the focus is on preventive putting these devices on.
So I have a relative who's happy married always, and her husband was having some heart issues, and he was having that passing out and not fall into the ground, but temporary,
Correct.
oh, you know, a little bit wakes up, that kind of stuff. And then all of a sudden, he's just really out of character and experiencing dementia, and he left the house, and he's doing crazy things, and he won't get cardiac. He won't go to a
So
doctor.
it's
So
hard
we were just
without-
talking
right.
about, like,
It's-
could that be related to his
right.
heart?
Yes,
He was
and
diagnosed with a heart, something, I just don't remember
Right.
what it was.
so yes and no. So there's a whole range of things that can cause people to faint or pass out temporarily. But the
Definitely
two,
heart.
right, the two commonest reasons are either the heartbeat stops abruptly and comes back, like we talked about for pacemakers, or the other thing is a rapid drop in blood pressure. So you drop in blood pressure, it's gravity dependent. As you lay down on the floor, blood circulation returns to your brain and you're up. So rapid drop in blood pressure could also work. Now, having said that, there are many conditions as we get older that affect the blood pressure regulation and the brain together. One of them being Parkinson's. There are many in that category that do it. So those kind of Parkinson-like patients can have both behavior changes with transient loss of consciousness. But without knowing more details, I can't comment.
We would like to help her to be getting with those things.
I would start with the primary care. But if he's fainting, it's not because the thing is, we need to know whether it's neurology related or heart related. That's the only reason why I said start with the primary care. But eventually, then I would say either way, you got to see both cardiology and neurology. But start with the primary care. Yeah, go ahead. I'm here all night. Don't worry.
Lyme disease, chronic Lyme disease. Do you know much about that and its impact on the electrical system in the heart? If it's undiagnosed or unconfirmed chronic Lyme. That's a long story too. The drugs that actually wearing for a while. Monitors and so on. And in her case, you couldn't get anyone that would just work one-on-one to college with you. Things like there might be something going on there. So like if she went to a cardiologist, she went to a referral.
Even starting with cardiologists, just for the rest of the members so that they're in our conversation here, that Lyme disease is like tick infection that tends to infect various things. You can have a skin rash, go out in the forest and there like you can take bites from that. You can have like joint pain, you can have rash. In some situations, it can also affect the electrical system of your heart and make your heart beat slow. And many of those may end up with a pacemaker, but there's a good percentage of people, if they are diagnosed in a timely fashion and actually treated with antibiotics, the heart rhythm may improve and they may not need a pacemaker.
So this is the case where she was fully treated for full off the charts, very serious, definite Lyme, which she had reached the point where it was later in the condition. And the question there is if that treatment was actually completed, everything that was wrong. And years out, it almost seems like it might not have been final and that she might be having chronic.
So when we look at Lyme, right, when we look at Lyme, at least from the electrical perspective, anything that goes up, it does show in the first few months. And that's corrected with the antibiotics for bigger brain. But if anything is showing up later, months, years apart, then it has to be treated as a regular heart rhythm. If she needs the heartbeat to slow, now she needs a pacemaker or so.
Would a cardiologist be able
Yes.
to tell if
Yes.
it's Lyme related or something else?
Yes, there are some blood tests cardiologists can order.
They can, even if because she was confirmed definitely had in the past, so those antibodies that would be there forever, basically.
Some would, some would not. Some would, some would.
So they'd be able to tell when she's treated.
I would say it's a good starting point. Yeah.
That it's coming back, so to speak, like those.
Yeah, it's Lyme is a different,
No,
Lyme is a different thing. It usually either you get it right away or it goes away. But it's hard to linger. Lyme effects don't linger. It's either caused the damage and it's there forever,
But those RP bacteria that can hide
but
out in the
not,
heart,
no,
you know,
no, they won't come back and hurt you. If they've damaged it, they've damaged. But yeah, starting with the cardiologist. Yes, sir.
When would you prescribe blood thinners to a defibrillator?
Right. So defibrillator patient never needs a blood thinner.
Why am I on it?
What blood thinner are you on? Aspirin, and again, I'm not going to get into personal because there's always a reason why you're on it.
There's two popular ones. The first one, it worked for years without any blood thinner.
So there are two categories of blood thinners. Ones we call aspirin, Flavixcan. Those are more for blockages. Those are more for stents. And then there are the other kind, which are the stroke risk ones, which is like the Xarelto, the Eliquis, the Warfarin.
Yeah, I was pushing, I was on both of them.
Okay.
But after 8 years, they decided one thing that I had one blood thinner. When I took it, I got such pains in my legs. I called him, I said, Doc, I can't take the long range benefit is not worth the pain I go through every night.
But are you talking about the blood thinner? Because the pain that you go through is more complex. The blood thinner don't really cause pain.
Well, it was the blood thinner because then I
See you again.
I was questioning every more time. Same thing, chemical makeup had same pain.
And I'm always a believer, no two individuals, they don't read textbooks. So there's always a reason that works for 99.9, it didn't work for you. But the main reason we give blood thinners is not defibrillators or pacemakers, it's to prevent strokes. And the two main reasons where these kind of blood thinners are given is one, if you have clots in your legs or in your heart, or mostly I would say clots in your lungs. So clots in your legs or lungs, we call DVT or pulmonary embolism. That's one reason. The other is if you have that irregular rhythm we talked about, atrial fibrillation, but pacemakers and defibrillators can also detect. So if we see that you're having those irregular rhythms making you prone for stroke, then we prescribe those. Those are the only two reasons I can think
Well,
that would do with me.
I couldn't take home. I called the doctor. The second guy was killing me every night. He said, well, you have something to talk with stroke. I said, I'll take the gamble. 2 weeks later, I had a stroke. And now they put me on warfarin, which is a lot milder, and I live with it.
Well, I won't call it milder. It's the first generation. But if you can't tolerate the other and you can tolerate warfarin, that's good. One thing that you can do is, and I'm guessing you have atrial fibrillation, and you may not feel it, but your pacemaker or defibrillator is picking it up and telling you that you have atrial fibrillation. So the one thing that you can do with the warfarin is, because the levels fluctuate a lot, there's so many things you eat that can cause interaction. Get your home monitoring system. So that way you can check it on a daily basis. Because if you go to the doctor's office and you're checking in once a month, you don't know what's happening the rest of the time. So if you have your own monitoring system, that makes it much more.
I met your son, but I had the one where you had to put it on your chest, rub it, pick it up, and now they got a regular one with a light. I just go in the room and pick it up.
Right. That's the one, the remote. But that's why I said, but keep a monitor for your blood testing. That will help you regulate and keep you more safe, especially if you've had a stroke. 1 second, I'm going to just go back.
We've got a question from online. What is
Where do I look?
Oh,
We don't look.
they don't see you.
Okay, good. But they hear me?
But they hear you,
Okay.
yes. And they saw your slides. So the question is, what is the likelihood that a person who has left bundle branch block will eventually require a biventricular pacemaker?
That is some really smart person out there. So left bundle branch block, as we talked a little, can they see my hands? No, they can't, they just hear me. So the heartbeat is supposed to beat left and right together. And many a times what happens is, if the electrical wiring of the left side is deranged, the electrical system goes first to the right. So the right gets stimulated, then comes to the left, and then the left gets stimulated. So just like we were talking about other scenario where the right and left don't beat together. So this is what left bundle branch does. It causes the heart not to beat together out of sync. Now, there are various reasons why left bundle branch happens. Sometimes it's just an electrical problem, and it could be a marker of blockages. So many times when we see left bundle branch block, we want to make sure there's no blockage issue. So many of the patients will need a stress test, or if they're having chest pain, they'll even get an angiogram. Now, there is a subgroup of patients who will eventually have the other wire also wear out, and they'll end up fainting. And these are the patients who would need a pacemaker. So if you have left bundle branch block and it changes and becomes complete heart block, then you get a pacemaker. Now, if your heart muscle is strong, then you get a regular pacemaker. If your heart muscle is weak, you get the 3-wire pacemaker. Was I able to answer that question? Because if your heart muscle is weak, it tells us that not only your heartbeat is getting slow, but your heart muscle is getting weak because the left and right are not working together. So in that scenario, we give you a 3rd wire. Now, having said that, is it quite often that left bundle will need a bileaf pacemaker in their lifetime? The answer is no. I know of people who've gone through their whole lives with left bundle and not needed a pacemaker. But there are others, as we get older, as the years pass by, it's a good possibility that you may need a pacemaker in the future. What determines the kind of pacemaker is how your heart muscle is. If it's weak, you may get a 3-wire. If it's strong, you may get a 2-wire.
Another question from online.
Was that question good enough for her? I don't know. Or not question, answer.
Let's see if they respond. Hopefully they'll respond and let us know. The next question is, how do we support patients that may develop social and emotional issues following pacemakers and or defibrillations in their heart?
Right. And this is again a very important aspect. I would say I hardly hear too many issues with pacemakers causing emotional, social issues. I mean, of course, it's a foreign object. You're living with somebody inside your heart, in your body. It takes a while to get used to it, especially the first few weeks. And again, just talking to your doctor or family support helps you get through it. But the majority of people do okay, because you know why they do okay? Because they were feeling bad and now they're feeling good. So that makes them all feel much better with it. But the bigger problem is the defibrillators. Why? Because the defibrillator guys didn't feel bad enough. Most of them didn't, and we're giving it to them as a preventive tool. So it creates a lot of, it depends upon the personality of the patient also. But I can't tell you that we have many what we call defibrillator social groups, support groups, where they meet and tell stories. The reason is twofold. One, you're always worried, when is it going to shock you? That creates stress. And it's easier for me to say, don't worry about it, it's going to save your life. Yes, but when? Tomorrow, the day after? So it is stressful. And again, it depends on individual personalities, But the other thing is, if somebody gets shocked from it, it saves their life, but it's hard. If you get one shock and you're good, I know people doesn't bother, I get one shock every 2 years, I'm alive, I'm playful. But you could get 20 shocks in 1 hour. And that's a nightmare. And those are the people who definitely need more support. So we need social support, but there is a good proportion of patients that need psychology aspect too. And if I have to just say which subgroup is the highest risk, those who've got multiple shocks in quick succession. That is the one category. I mean, you can always tell them you're alive, but it's easier said than done. But that's a big emotional support that they have to. And I spend a lot of time with my defibrillator patients, discussing those aspects.
The first person said thanks. So I think you did answer their question fully. Thank you.
And, we are, again, there are things that become priority, and, it's how things work these days. Everything is cost driven, and, patients and physicians are not the priority for our healthcare. You didn't hear this. But this is something I've been trying to do for a while, is to start a defibrillator support group, and hopefully I can do it sometime in the next few years, because it's very important.
I
Anything
think we
else?
should do that.
I'll need your partnership on that. No, and that's one of my things I have to
I
do.
think that's an awesome.
I don't care who gets paid or doesn't get paid. I need to get that.
Excellent presentation.
Thank you. Everybody's awake, that's good enough.
Thank you.
Any more questions or? If not, I'll take your emails on your way out.
All good?
Thank you.
You look, you might have one more.